Liver, anatomy of liver and its blood supply. 1. 2 ND largest organ in human body after skin. 2. Location, upper right quadrant. 3. Weight, 1.4 to 1.6 kilograms. 4. Blood supply, dual blood supply through hepatic artery 25%, and hepatic portal vein, 75%. Half of oxygen requirement is met by hepatic artery and rest is met by hepatic portal vein. 5. Cardiac output, receive 25% of CO, with total blood flow of around 1.5 L min. 6. Venous drainage, left, right and middle hepatic veins to inferior vena cava. 7. Live is divided into right and left lobes by falciform ligament, with right lobe being large. 8. Each liver lobe is subdivided by right and left hepatic veins into 4 sections, medial and lateral sectors on left side, posterior and anterior sectors on right side. These sectors divided into segments, each with its own blood supply and biliary drainage. 9. Anatomically, functional unit of life is lobule. Blood enters lobule through branches of portal vein and hepatic artery, flowing through small channels called sinusoids which are lined by hepatocytes. 10. Metabolic perspective, functional unit of liver is hepatic acinus. Each acinus is divided into zones correspond to their distance from arterial blood supply. Hepatocytes lying close to arterioles are best oxygenated zone. Periportal zone, hepatocytes with further distance from arterial blood supply have poor oxygen supply. Zone 2, hepatocytes having poorest oxygen supply. Zone 3, centrilobular zone, most sensitive to ischemic injury. Metabolic, functional unit of liver, hepatic acinus. Liver lobe subdivisions, hepatic lobule. 11. Zone I, hepatocytes specialized for oxidative liver functions such as gluconeogenesis. 12. Zone 3, hepatocytes specialized for glycolysis, lipogenesis and CYP450 base drug detoxification. These hepatocytes are most sensitive to N-actylp benzoquinonamine NAPQI production and paracetamol overdose having highest. Live is divided into right and left lobes by falciform ligament, with right lobe being large. 8. Each liver lobe is subdivided by right and left hepatic veins into 4 sections, medial and lateral sectors on left side, posterior and anterior sectors on right side. These sectors divided into segments, each with its own blood supply and biliary drainage. 9. Anatomically, functional unit of life is lobule. Blood enters lobule through branches of portal vein and hepatic artery, flowing through small channels called sinusoids which are lined by hepatocytes. 10. Metabolic perspective, functional unit of liver is hepatic acinus. Each acinus is divided into zones correspond to their distance from arterial blood supply. Hepatocytes lying close to arterioles are best oxygenated zone. Periportal zone, hepatocytes with further distance from arterial blood supply have poor oxygen supply. Zone 2, hepatocytes having poorest oxygen supply. Zone 3, centrilobular zone, most sensitive to ischemic injury. Metabolic, functional unit of liver, hepatic acinus. Liver lobe subdivisions, hepatic lobule. 11. Zone I, hepatocytes specialized for oxidative liver functions such as gluconeogenesis. 12. Zone 3, hepatocytes specialized for glycolysis, lipogenesis and CYP450 base drug detoxification. These hepatocytes are most sensitive to N-actylp benzoquinonamine NAPQI production and paracetamol overdose having highest concentration of CYP2E1 enzyme. Factors affecting hepatic blood flow, increased by, decreased by. Supine position, upright positioning, ingestion of food. IPPVP, hypercapnia, hypocapnia, acute hepatitis, hypoxia. Drugs, barbiturates, P450 inducers, cirrhosis drugs, propofol, inhalational agents, B blockers. Function of liver, metabolic function, carbohydrate metabolism, short-term and long-term maintenance of glucose concentration, glycogenesis, glycogenolysis, gluconeogenesis, fat metabolism, synthesis of lipoprotein, cholesterol, phospholipids, conversion of carbohydrate and proteins into fatty acids and triglycerides, protein metabolism, conversion of amino acid to glucose and lipids, synthesis of urea, synthesis of non-essential amino acids, synthesis of plasma protein, coagulation factor, production factor I. Metabolic function, carbohydrate metabolism, short-term and long-term maintenance of glucose concentration, glycogenesis, glycogenolysis, gluconeogenesis, fat metabolism, synthesis of lipoprotein, cholesterol, phospholipids, conversion of carbohydrate and proteins into fatty acids and triglycerides, protein metabolism, conversion of amino acid to glucose and lipids, synthesis of urea, Synthesis of urea, synthesis of non-essential amino acids, synthesis of plasma protein, coagulation factor, production factor I, 2, V, 7, 9, X, Xi, protein CNS, bile production and excretion, insulin-like growth factor. Thrombopoietin production, albumin production, hormone synthesis, storage of glycogen, vitamin A, D, B12, iron and copper, drug and toxin metabolism, phase 1 and phase 2, phagocytic function, sinusoids lined by endothelial cells, interspersed with tissue macrophages called Kupffer cells to remove particulate matter, formation of lymph, liver contributes to total 50% of lymph production, liver function test, LFTS, these are divided into test of liver function. Prothrombin time PT, measure extrinsic pathway of coagulation, it measures factor I, 2, V, 7, X, prolongation, reflect deficiencies of vitamin K either due to impaired absorption from poor quality of bile production, or abnormalities in factor 7 synthesis, both relating to liver dysfunction. It is best prognostic marker for alpha-albumin production. Low serum albumin, hypoalbuminemia reflect liver dysfunction, can also be present in malnutrition. Nephrotic syndrome, malabsorptive states, late pregnancy, test of cell injury, ALT-SGPT, alanine aminotransferase. These tests detect liver cell damage. AST-SGOT, aspartate aminotransferase, test of biliary obstruction, bilirubin levels. Note, jaundice, serum bilirubin, 2 negative 3 mg/dl, levels seen in hemolysis, biliary stricture, hepatitis, cirrhosis, drugs, congenital syndrome, Gilbert, alkaline phosphatase, ALP, levels seen in biliary duct obstruction, i.e. stone. Drugs, cancer, pregnancy, Paget disease, gamma-glutamyl peptidase, GGT, levels seen in liver disease, biliary disease, pancreatic disease, CCF. Drugs, phenytoin, barbiturates, NSAIDs, acute liver failure. It is defined as rapid development of jaundice, coagulopathy, encephalopathy, in patient without prior liver disease. Classification of acute liver failure. Hyperacute failure, onset within 7 days, acute failure onset between 8 and 28 days, subacute onset between 4 weeks 24 weeks. Common causes for acute liver failure. Drugs, paracetamol overdose, increase alcohol intake, medicine reaction, infections, acute viral hepatitis AE, cytomegalovirus EBV, seronegative hepatitis, others, acute fatty liver of pregnancy, Wilson disease, Rice syndrome, zone I. Hepatocytes specialized for oxidative liver functions such as gluconeogenesis. Necrosis of this zone is seen in phosphorus poisoning, eclampsia, zone 2. Necrosis is rare and seen in yellow fever, zone 3. Hepatocytes specialized for glycolysis, lipogenesis and CYP450 drug detoxification. These hepatocytes are most sensitive to N-acetylp-benzoquinone NAPQI. Production and paracetamol overdose having highest concentration of CYP2E1 enzyme. Necrosis of this zone is seen in ischemic injury and toxins such as paracetamol poisoning. Clinical features: nonspecific nausea and abdominal discomfort, confusion, coma and agitation. King College criteria for liver transplant in acute liver disease, chronic liver disease, CLD. It is defined as progressive clinical features is nonspecific nausea and abdominal discomfort, confusion, coma and agitation. West Haven criteria for semi-quantitative grading of mental status: trivial lack of awareness, euphoria or anxiety, shortened attention span, impaired performance of addition, lethargy or apathy, minimal disorientation for time or place, subtle personality change, inappropriate behavior, impaired performance of subtraction, somnolence to semi-stupor, but responsive to verbal stimuli. Confusion, gross disorientation, coma, unresponsive to verbal or noxious stimuli, hepatic encephalopathy. Clinical manifestations: grade EL, grade LL, reduced attention span, moderate, confusion, slurred speech, sleepy, but arousable. Severe confusion, incoherent speech, grade 1, grade 2, grade 3, grade 4, grade I, grade IV, generally alert, but with sleep irregularities, mild confusion, mildly slowed speech, hysterexes, personality changes, coma, ataxia, disinhibition. Bizarre behavior, Dr. Fahad Butt, Dr. Ahmed Shabazz, King College criteria for liver transplant in acute liver disease, acetaminophen-induced, ALF, arterial pH 7.30 after food resuscitation, or all of the following. Prothrombin time, 100 seconds, serum creatinine, 3.4 mg/dl, encephalopathy, grade 3 or 4 hepatic, non-acetaminophen-induced, ALF, prothrombin time, 100 seconds, or any three of the following, non-A, non-B viral, hepatitis, drug-induced or indeterminate etiology of ALF, time from jaundice encephalopathy, 7 days, age, 10 years or 40 years, prothrombin time, 50 seconds serum bilirubin, 174 mg/dl, Dr. Fahad Butt, Dr. Ahmed Shabazz, chronic liver disease, CLD. It is defined as progressive destruction and regeneration of liver parenchyma fibrosis and cirrhosis, recurrent and sustained inflammation of liver parenchyma, fibrosis, scarring and nodular regeneration, irreversible damage to the liver architecture. Cirrhosis, portal hypertension, complications, causes of CLD, infection, viral hepatitis B and calum with cytomegalovirus and EBV1. 2. Toxins, alcohol, amiodarone and methotrexate, autoimmune diseases, autoimmune hepatitis, primary biliary sclerosis, primary sclerosing cholangitis. 3. 4. Metabolic cause such as non-alcoholic steatohepatitis, NASH, hemochromatosis, alpha-1 antitrypsin deficiency and Wilson disease, congestive cardiac failure, cardiac cirrhosis. 5. Clinical features, clubbing, spider nevi, gynecomastia, caput medusa, flapping tremors of body and tongue, hyperdynamic circulation, palmarerythema, scratch marks, testicular atrophy, alopecia, widened pulse pressure, encephalopathy. Dr. Fahad Butt, Dr. Ahmed Shabazz. Note: encephalopathy usually develops in patients with CLD. It can be precipitated by infection, GI bleeding, sedative medicines, electrolytes disturbance, hypoxia and protein overload. Classification of liver disease, chronic liver disease assessment. Child-Pugh score, score 2. 2835 GL, slight 34.2 to 51.3 UMOL, grade 1-2, 46, 1.7 to 2.3, 1-year survival, percent, 2-year survival, percent, 100, 80, 45, 85, 60, 35, 1, 35 GL, absent, 34.2 UMOL, none, 4, 1.7, parameters, albumin, ascites, bilirubin, encephalopathy, seconds over control, INR, class, A, B, C. 3, 28 GL, moderate, 51.3 UMOL, grade 3-4, 6, 2.3, score, 5 6, 7 9. 10-15, description, well-compensated disease, significant functional compromise, decompensated disease, table 8.3, surgical risk assessment, child's classification, as modified by Pugh, mortality, bilirubin micromoles L, albumin GL, PTS, prolonged, iniurininase, ascites, encephalopathy, nutrition, minimal, 5%, 25, 35, 14, none, none, excellent, modest, 5 to 50%. 25-40, 30-35, 4-6, moderate, grades INEL, good, INR, international normals ratio, PT, prothrombin time, marked, 50%, 40, 30, 6, marked, grades 3, NIV, ME, poor, Dr. Fahad Butt, Dr. Ahmed Shabazz. Physiological changes associated with liver disease, cardiovascular, hyperdynamic circulation, low SVR, increased cardiac output, hypotension, low SVR may mask underlying cardiomyopathy and coronary artery disease. Anesthesia can unmask these. Diaphragmatic splinting due to ascites, JFRC, atelectasis and hypoxia, pleural effusion, intrapulmonary arteriovenous shunting, hepatopulmonary syndrome, ARDS with or without sepsis, portopulmonary hypertension, hypoperfusion. From decreased vasodilating, prostaglandins, sequestration of blood, renal failure due to hepatorenal syndrome, encephalopathy, coma, confusion, anemia, blood loss, hemolysis from hypersplenism, anemia of chronic illness, bone marrow depression or nutritional deficiency, coagulopathy, prolongation of PT, indicating hepatocellular necrosis, thrombocytopenia due to portal HTN leading to splenomegaly, leukopenia, drug with high extraction ration, e.g., morphine. Pethidine. These depend on hepatic blood flow for clearance, so decrease the dose of drug but not the frequency, drug with LOW extraction ratio. E.g., warfarin and theophylline. These depend on metabolic capacity of liver, so no need to decrease the dose, only prolonged dosing interval. Respiratory, renal, CNS, hematological changes, drugs handling, Dr. Fahad Butt, Dr. Ahmed Shabazz. Infection risk, GIT, increase risk of sepsis. Gram-positive organism, and fungal infection leading to sepsis. Portal hypertension leads to ascites, esophageal varices, hemorrhoids, gastrointestinal bleeding. Treatment include sclerotherapy, endoscopic ligation, B blockers, vasopressin, somatostatin analogs. Tips: hypo and hypernatremia, hypokalemia, hypocalcemia, hypomagnesemia, hypophosphatemia, hypoalbuminemia, hypoglycemia, metabolic alkalosis, metabolic syndrome, cirrhosis. It is a pathological condition where normal architecture of liver is distorted due to development of fibrous tissue and formation of regeneration nodules, which is accompanied by decreased hepatocellular mass, function and alteration of blood flow. In response to chronic liver injury resulting in portal hypertension and end-stage liver disease, Casus.1. Infection, viral hepatitis B and C along with cytomegalovirus and EBV. 2, 3. Toxins, alcohol, amiodarone and methotrexate. Autoimmune diseases, autoimmune hepatitis, primary biliary sclerosis, primary sclerosing, cholangitis. Metabolic cause such as non-alcoholic steatohepatitis, NASH, hemochromatosis, alpha-1 anti-4, trypsin deficiency and Wilson disease. 5. Congestive cardiac failure, cardiac cirrhosis, Dr. Fahad Butt, Dr. Ahmed Shabazz. Classification of cirrhosis, morphological classification, histological classification, etiologic classification, functional classification. Pathophysiology of cirrhosis, cirrhosis, portal, macronodular, micronodular and mixed portal, post-neck. Morphological classification, macronodular, micronodular and mixed portal. Histological classification, etiologic portal, post-necrotic, post-hepatic, biliary and congestive, genetic. Etiologic classification, genetic, toxic, infection, biliary, vascular. Child-Pugh classification. Functional classification, pathophysiology of cirrhosis, cirrhosis, macronodular, micronodular. Hypertension, splanchnic arterial vasodilation, reduction in effective arterial volume, activation of vasoconstrictor systems, renin-angiotensin, sympathetic nervous, arginine vasopressin systems, normalization of vasoconstrictor systems. Persistent activation of vasoconstrictor systems, normal excretion of sodium in water, no ascites, retention of sodium, ascites, retention of water, renal, vasoconstriction, hyponatremia. Hepatorenal syndrome, Dr. Fahad Butt, Dr. Ahmed Shabazz. Compilations of cirrhosis, portal hypertension, varices, esophageal, ascites, splenomegaly, portopulmonary hypertension, cirrhotic cardiomyopathy, liver failure, hepatic encephalopathy, hepatorenal syndrome, hepatopulmonar syndrome. Spontaneous bacterial peritonitis, portal hypertension. It is defined as increase in hepatic venous pressure gradient to 5 mm Hg. Caused by increased resistance to hepatic blood flow due to cirrhosis and regenerative nodules, and increased splanchnic blood flow due to splanchnic vasodilation, hepatic fibrosis, arterioportal shunting, endothelial dysfunction, intrahepatic vascular tone, pulsatile retrograde portal venous flow, vascular resistance, within hepatic sinusoids, portal hypertension, endogenous vasodilators no, released by splanchnic vasculature, systemic hypotension. High output cardiac failure, renal hypoperfusion, redistribution of blood from systemic to splanchnic, vasculature, angiogenesis, collateral drainage pathways, variceal, hemorrhage, F-splanchnic, hydrostatic pressure, ascites, NaNHD retention. Translocation of gut bacteria, diluted antibacterial, complement protein, hepatorenal syndrome type 1, sepsis, spontaneous bacterial peritonitis, Dr. Fahad Butt, Dr. Ahmed Shabazz, increased hepatic resistance, variceal, bleeding, virical. Formation, systemic, vasodilatation, renin-angiotensin, nitric oxide, aldosterone system activation, ascites, sympathetic nervous system activation, antidiuretic hormone, hyponatremia, hepatorenal syndrome, gut-derived peptides. Portal hypertension, translocation of gut bacteria, shear stress nitric oxide, increased portal inflow, causes of portal hypertension, PRE hepatic, PRE sinusoidal intrahepatic. Post-sinusoidal intrahepatic post-sinusoidal complications of portal hypertension, varices, splenomegaly, ascites, treatment of acute variceal bleeding, general measure. Fluid resuscitation and replacement of blood by blood products, hemodynamic, and respiratory support specific measure to control bleeding, measure to prevent hepatic encephalopathy, splanchnic, vasodilatation, splenic ave fistula. Portal vein thrombosis, massive SVC obstruction, sarcoidosis, primary biliary cirrhosis, established cirrhosis, alcoholic hepatitis, idiopathic pulmonary hypertension, veno-occlusive disease, Budd-Chiari syndrome, constrictive pericarditis. Dr. Fahad Butt, Dr. Ahmed Shabazz, specific measure to control bleeding, pharmacological measures, causing vasoconstriction to stop bleeding, vasopressin, terlipressin, somatostatin analog, octreotide, mechanical measures. Inflatable balloons for tamponade by direct pressure, Sengstock and Blackamoor tube consisting of esophageal and gastric balloon, Minnesota tube, Linton Nachlas tube consisting of single gastric balloon, surgical measures, endoscopic variceal ligation. Management of portal hypertension and cirrhosis, treatment of offending agent cause, decrease hepatic venous pressure gradient, somatostatin, octreotide, vasopressin. Measure to lower portal venous pressure and treatment of portal hypertension complications, B blocker, proneolol, diuretics, spironolactone, loop diuretics for ascites, portosystemic shunt procedures, transjugular intrahepatic portosystemic shunt tips. If tips not available, then surgically created portosystemic shunt can be done. Types of surgical shunt for portal hypertension: total shunts, partial shunts, selective shunt. Dr. Fahad Butt, Dr. Ahmed Shabazz, portopulmonary hypertension. IT is defined as mean PAP, 25 mmHg in patients with liver diseases, cirrhosis, or portal hypertension, Budd-Chiari syndrome, veno-occlusive disease, chronic infections, etc., chronic liver disease, portal hypertension, hyperdynamic. Circulatory state, hepatic dysfunction, splanchnic vasodilation, decreased hepatic blood flow, shear stress from increased systemic blood flow, increased ET1, IL-6 imbalance of other circulating factors, endothelial cells. EAT-1A receptors upregulated, loss of prostacyclin synthase expression, smooth muscle proliferation, vasoconstriction, portosystemic, shunting, bacterial translocation, systemic inflammation, lung, genetic factors, platelet aggregation 32, in situ thromboses, vascular remodeling, pulmonary artery hypertension, hepatopulmonary syndrome. It is triad of liver disease, hypoxemia and intrapulmonary vascular shunting leading to VQ mismatch and increase AA gradient. Patient may develop platypnea. SOB relived by lying down and increased by sitting or still standing up. Orthodexia, hypoxemia worsen upright position and improve on lying down. Cirrhosis, hepatic dysfunction, increase in endogenous vasodilators. Inactivation of exogenous toxins is impaired. Hyperdynamic circulation, hepatopulmonary syndrome, portal hypertension, systemic, vasodilatation, increased, shunts. Dr. Fahad Butt, Dr. Ahmed Shabazz, normal, portopulmonary hypertension, POF. Alveolus, hepatopulmonary syndrome, HPS, alveolus, capillary. 8-15M, vasoconstriction and vascular obstruction 8-15M, due to proliferation of smooth muscle, endothelium and platelet aggregates, dilated, capillary and angiogenesis. 15-100 pm, hepatorenal syndrome. It is defined as elevated creatinine, 1.5 mgd in patient with cirrhosis and ascites that persists once. Other pathogens excluded or treated. Type 1 HRS. Progress rapidly. Require hemodialysis and liver transplantation. Type 2 HRS, more stable and responsive to conservative treatment, i.e. terlipressin. Tips: cirrhosis, portal hypertension, splanchnic arterial vasodilation. Decreased systemic vascular resistance, arterial underfilling, stimulation of systemic vasoconstrictors, renal vasoconstriction, late stages of cirrhosis, decrease in local vasodilators with increase of local vasoconstrictors. Hepatorenal syndrome, early stages of cirrhosis, increased systemic and local vasodilators, preserved renal perfusion. Dr. Fahad Butt, Dr. Ahmed Shabazz, factors contributing to coagulopathy and cirrhosis, thrombocytopenia due to sequestration. decrease thrombopoietin and DIC and qualitative platelet, dysfunction impaired coagulation factor synthesis, hypofibrinogenemia, coagulation factor consumption due to accelerated fibrinolysis and DIC, altered activity of coagulation factors, gamma carboxylation, dysfibrinogenemia. And vitamin K deficiency, decrease breakdown of plasminogen, increase fibrinolysis, factors contributing to anemia in cirrhotic patient, chronic GI blood loss notional deficiencies, hyper. Splenism related to portal hypertension, direct bone marrow suppression, ascites. It is pathological accumulation of fluid in peritoneal cavity, a complication of portal hypertension, can be generalized or localized. Causes of generalized accumulation of fluid, decreased synthetic function of liver hypoalbumin A, which leads to reduced oncotic pressure and leaking of fluid into peritoneal cavity. No induced vasodilation, activation of renin-angiotensin aldosterone system with sodium retention. Causes of localized accumulation of fluid. Raised intrahepatic vascular resistance with portal hypertension along with splanchnic vasodilation leading to increased portal flow and increased splanchnic production of lymph due to raised portal venous flow and due to seepage of lymph from lymphatic channels disrupted by nodular regeneration. Dr. Fahad Butt, Dr. Ahmed Shabazz, Pathophysiology of ascites, cirrhosis, L-albumin. 1. Aldosterone metabolism, aldosterone, activation of renin-angiotensin system, underfilling of circulation, renal, blood flow, splanchnic vasodilation, lymph formation exceeds lymph return, oncotic pressure, transudation of fluid, portal. Hypertension, salt and water retention, ascites, Dr. Fahad Butt, Dr. Ahmed Shabazz, complication of ascites, refractory ascites, spontaneous bacterial peritonitis, refractory ascites. Ascites unresponsiveness to spironolactone amiloride furosemide daily for 2 weeks. Treatment, large volume paracentesis less than 5 L with albumin replacement, peritoneal venous shunt in selected patients with good hepatic reserve. Relative contraindication to shunt procedures are previous abdominal surgery, spontaneous bacterial peritonitis, large veins, spontaneous bacterial peritonitis, more common in patients with severely decompensated jaundice. It is a clinical syndrome where ascites become infected in absence of recognizable cause of peritonitis. Diagnosis of SBP is by paracentesis. Gold standard for diagnosis of SBP is polymorph nuclear count, 250 cell microliter. Secondary bacterial peritonitis, multiple organism ascitic fluid protein concentration, 1 GDL, leukocytosis. Even antibiotic therapy culture remain positive. Ascites management, spontaneous bacterial peritonitis. Single organism ascitic fluid protein concentration 1 GDL, there is rapid fall in white blood cell count. It becomes sterile quickly. Salt restricted diet, water restriction only if patient has hyponatremia. Spironolactone 100 -200 mg day increase up to 400 -600 mg day. Furosemide 40 -80 mg day can increase to 120 -160 mg added in patient with peripheral edema. If ascites persists despite above refractory ascites. Repeated large volume abdomen paracentesis with albumin replacement needed. Tips, SOD, 1.1 mg/dl, cirrhosis, alcoholic hepatitis, cardiac ascites, mixed ascites, massive liver metastasis, fulminant hepatic failure, BUD. Chiari syndrome, portal vein thrombosis, veno-occlusive disease, myxedema, SOD, 1.1 mg/dl, peritoneal carcinomatosis, tuberculous peritonitis, pancreatic ascites, bowel obstruction, biliary ascites, nephrotic syndrome. Postoperative lymphatic, leak, serositis and connective tissue disease, transudate, hypoalbuminemia e.g., nephrotic syndrome, raised central venous pressure, chronic liver disease, portal vein obstruction, congestive cardiac failure, exudate. Malignancy, chylous ascites, hepatic vein obstruction, Budd-Chiari syndrome, pancreatitis, inflammatory bowel disease, Dr. Fahad Butt, Dr. Ahmed Shabazz, hepatic encephalopathy. It is defined as alteration in mental status and cognitive function occurring in presence of liver failure. Pathophysiology. Encephalopathy occurs because neurotoxins produced in gut reach brain due to protosystemic shunting as well as failure of liver to detoxify them due to reduced hepatic mass and function. Encephalopathy occurs because neurotoxins produced in gut reach brain due to protosystemic shunting as well as failure of liver to detoxify them due to reduced hepatic mass and function. Cirrhosis. A damaged liver cannot break down ammonia properly, which can lead to hyperammonemia. Hemodynamic causes of hyperammonemia: portal hypertension or collateral circulation bypass the liver, gut, liver. Metabolic causes of hyperammonemia: impaired detoxification of ammonia via the urea cycle and glutamine, kidney, NH. Urea glutamine cycle, NH, hyperammonia, liver, NH, brain, hepatic encephalopathy, Dr. Fahad Butt, Dr. Ahmed Shabazz. Signs of hepatic encephalopathy, number 1, behavior and impulse control issues, mood and personality swings. Problems with memory, concentration and thinking, consciousness, lucidity and sleep pattern changes, loss of autonomy and ability to care for yourself. Hepatic encephalopathy clinical manifestations: grade I, grade ill, reduced attention span. Moderate, confusion, slurred speech, sleepy, but arousable. Severe, confusion, incoherent speech, coordination and motor function problems. Grades of encephalopathy: grade I, grade IV, generally alert, but with sleep irregularities, mild, confusion, mildly slowed speech, hysterexes, personality changes, coma, ataxia, disinhibition, bizarre behavior. Copyright O Strong Medicine. Dr. Eric Strong, Dr. Fahad Butt, Dr. Ahmed Shabazz. Factors precipitating hepatic encephalopathy: factors increasing nitrogen load, GI bleeding, excess dietary protein, azotemia, constipation, disturbance of internal milieu, hypovolemia. Metabolic alkalosis, acidosis, hypoxia, hyponatremia, hypokalemia. Management of hepatic encephalopathy: identify and correct precipitating factors, initiate ammonia lowering, therapy, drug, narcotic, tranquilizers, sedatives, miscellaneous. Infection, surgery, progressive liver disease. Tips for potential complications of cirrhosis and depressed consciousness minimized by supportive care with attention to airway, hemodynamics and metabolic status. Assess for vital signs and volume. Status: evaluate if there is any GL bleed or not. Eliminate the use of sedatives and tranquilizers. Screen for hypoxia, hypoglycemia, anemia, hypokalemia. Metabolic alkalosis. Use NG lavage, lactulose therapy. Lactulose produces bowel movements. 2. For an average, neomycin 412G day. It is non-absorbable antibiotic which reduces intestinal bacterial content. Flumazenil or other benzodiazepine receptor antagonist. Dr. Fahad Butt, Dr. Ahmed Shabazz. Model for end-stage liver disease, MELD. This model was initially developed to predict survival in cirrhotic patients undergoing liver transplant, but it turns out to be most accurate in predicting outcomes in non-transplant surgery than Child-Pugh. Current studies recommend that patient undergoing non-transplant surgery. Child-Pugh classification predicts 30 days mortality. MELD predicts 90 days/3 months mortality. MELD NA predicts 1 year mortality. Model for end-stage liver disease, MELD, score, MELD equals 3.78 x log, serum bilirubin mgdl, plus 11.20 x log, INR plus 9.57 x log, serum creatinine mgdl, plus 6.43, constant for liver disease etiology. Notes: if the patient has been dialyzed twice within the last 7 days, then the value for serum creatinine used should be 4.0. Any value less than 1 is given a value of 1, i.e. if bilirubin is 0.8. A value of 1.0 is used to prevent the occurrence of scores below 0. The natural logarithm of 1 is 0, and any value below 1 would yield a negative result. MELD score 10, MELD score 10, 15, MELD score 15. Low risk for elective surgery. Intermediate risk for elective surgery. High risk for elective surgery. It should be postponed as there is high mortality. NA is added to MELD formula for further evaluation of cirrhotic patient. MELD NA equals 0.025 x MELD x 140 NA plus 140. Dr. Fahad Butt, Dr. Ahmed Shabazz, John Side. Normal total bilirubin is composed of conjugated direct water-soluble and unconjugated indirect lipid-soluble form. It is usually 1.5 mgdl, which reflects balance between bilirubin production and excretion. Jaundice is clinically evident when total bilirubin exceeds 3 mgdl. It is defined as yellow discoloration of the skin, sclera and other tissues, caused by deposition of excess circulatory bilirubin. Formation and metabolism. Bilirubin is formed in reticuloendothelial system, i.e. liver and spleen, when heme is broken down. 70 to 80% from breakdown of RBC and 20 to 30% from other heme protein. Unconjugated indirect bilirubin is water insoluble and is transported bound to plasma albumin in presence of glucuronyl transferase. Bilirubin is conjugated first to mono then D. Glucuronide bilirubin, which is conjugated or water-soluble bilirubin to. In the intestine, bacteria metabolize bilirubin to form urobilinogen, most of urobilinogen converted stercobilins, which is excreted into stools. Some urobilinogen excreted unchanged in urine. Type of jaundice, S. bilirubin, liver enzyme coagulopathy, response to vitamin K, hemolytic jaundice, modest increase, mostly unconjugated normal, absent normal coagulation. Causes of postoperative liver dysfunction or jaundice, bilirubin overload, hemolysis, blood transfusion, hematoma, resorption, hemolytic anemia, sickle cell, prosthetic heart, valve, glucose 6-phosphate dehydrogenase deficiency. Exacerbation of pre-existing liver disease, hepatic ischemia, hypovolemia, hypotension, cardiac failure, septicemia, drug-induced antibiotics, halothane, hypoxia, viral hepatitis, intrahepatic, benign, infection, drug-induced, e.g., cephalosporins. Carbamazepine, erythromycin, extrahepatic pancreatitis, gallstones, bile duct injury, obstructive jaundice, high, mostly conjugated, ALP GGT raised, may be present, yes, hepatocellular, jaundice, high, both conjugated and unconjugated. Ast alt raised, can be present, absent, yes, no, hepatocellular injury, cholestasis, Dr. Fahad Butt, Dr. Ahmed Shabazz, congenital, Gilbert syndrome, standard precautions in case of needle stick injury in patient with hepatitis B. Use of protective barriers, gloves for handling of mucous membrane, body, fluids, broken skin, wear goggles, gown and mask during procedure, such as needles, sutures, bandages, dressings, anything contaminated with body fluid and waste. Must be handled with gloves and disposed. While handling sharps, don't recap needles. Put containers within arm reach, such as speculums, surgical instruments and thermometers disinfected. When available, take vaccines hepatitis A and B. Wash wound gently with soap and water. Let the wound bleed freely. Irrigate mucooral surfaces with saline, sharps, reusable instruments. Immunization, wound care after exposure. Dr. Fahad Butt, Dr. Ahmed Shabazz. Preoperative assessment in liver failure. Patient came for surgery. Prediction of surgical risk is based on degree of liver dysfunction, type of surgery. Preclinical status of patient. Child Pew score is used to estimate risk of perioperative mortality. Child A, 5 to 10%. Perioperative mortality. Child B, 25 to 30%. Perioperative mortality. Child C, 50%. Perioperative mortality. For all types of surgeries, patient undergoing emergency surgery is even at greater risk. Preoptimization of electrolytes, intravascular volume status, coagulation and infection status. Preoperative vitamin K and FFP given to correct coagulation profile and cryoprecipitate given if PT remains. Prolonged herniation and respiratory ascites at the time of surgery causes wound dehiscence, abdominal wall. Compromise secondary to diaphragmatic splinting, so preoperative diuresis or aggressive paracentesis may be required. Ascetic fluid removal done either at preoperative or intraoperative at laparotomy cause significant fluid shift and intravascular volume depletion and precipitates cardiovascular collapse, so boluses of colloid and form of albumin replacement required. Depending upon volume of ascites removed, nutritional health should be addressed preoperatively and diet input and vitamin supplements should be started as early as possible. Gastric emptying is delayed so aspiration risk is high. Medicate with H2 receptor antagonist. Sedative premedication avoided as it may precipitate encephalopathy. Other identifiable causes of encephalopathy such as infection, electrolytes disturbance, GI blood loss, avoided or treated where possible. Preoperative assessment, investigations required, FBC check. Anemia, thrombocytopenia, evidence of infection, anemia by chronic blood loss, hypersplenism, hemolysis, chronic illness and malnutrition, coagulation profile. PT. Synthetic function of liver indicator of hepatocellular function. Electrolytes and creatinine ice often falsely low due to D-hepatic production. Hyponatremia and hypokalemia are common. Diuretic use may exacerbate electrolyte disturbances, glucose-impaired glycogen storage and glucose utilization. Hepatitis screening. Hepatitis B and C are highly contagious to clinical staff via parenteral Inoculation and universal precautions must be strictly followed. Assessment of liver function, serum LFTs, prothrombin time PT, albumin and bilirubin are sensitive markers of overall liver function. Avoid giving fresh frozen plasma, FFP, unless treating active bleeding, as PT is an excellent guide to overall liver function. LFTs must always be interpreted alongside a careful history and examination. The liver has a large functional reserve and can often withstand considerable damage before LFTs become deranged. Liver transaminases aspartate transaminase AST, alanine aminotransferase ALT are sensitive to even mild liver damage. Dr. Fahad Butt, Dr. Ahmed Shabazz, alkaline phosphatase, ALP, is raised with biliary obstruction. Imaging techniques, ultrasound is the main initial investigation of obstructive jaundice. Other investigations include ERCP, CT and magnetic resonance cholangiography. Cardiac ECG is essential as electrolyte abnormalities may precipitate arrhythmias and alcohol excess may result in AF and cardiomyopathy. Prolonged corrected QT is relatively common, and hyperbilirubinemia may precipitate bradyarrhythmias. Echocardiography, cardiomyopathy may develop in association with causes of CLD, particularly alcohol excess. Pericardial effusions and diastolic dysfunction also develop in cirrhosis. Smoking is associated with alcohol excess and is an independent risk factor for CAD. Respiratory, CXR, ABG. Nutrition, CLD is associated with a poor nutritional state and predisposes to increase incidence of postoperative complications. Preoperative nutrition may help to reduce this in major elective surgical procedures. The presence of varices in patients with known liver disease must be established. As this is a contraindication for the use of esophageal Doppler probes, toe and esophageal temperature probes, perioperative considerations, premedications, people or H2 antagonists should be used preoperatively. RSI will further reduce the risks of gastric aspiration. Sedative medication may precipitate or worsen encephalopathy. Standard monitoring should be used, with consideration given to invasive arterial and CVP monitoring. CVP monitoring is controversial but allows for centrally administered vasopressors and venous access. Perioperative hemodynamic instability can worsen hepatic function. MAP should be maintained within 10 to 20% of preoperative levels. Hepatic blood flow and O2 delivery should be maintained. CO monitoring may be useful, although transthoracic echocardiography or esophageal Doppler may be contraindicated in varices, even in severe liver disease. The problem is usually one of exaggerated effects on the CNS, rather than page 0 or liver metabolism. Monitoring, drug effects. Dr. Fahad Butt, Dr. Ahmed Shabazz, hepatic blood flow is altered by anesthetic, drugs e.g., AN6 agonists antagonists. Positive pressure ventilation, PPAN, surgical technique. In most cases, anesthesia reduces hepatic blood flow. Desflurane best preserves hepatic blood flow, is least metabolized and has a quicker emergence time, but sevoflurane and isoflurane are also acceptable volatiles to use, can be useful adjuncts. But Neuraxyl techniques are contraindicated in the presence of coagulopathy. Most LAs are metabolized by the liver. Low SVR and arterial pressure, increase HRN volume expansion 2 degrees to an activated renin-angiotensin system seen in both ALF and CLD. Vasopressors may be required. Maintain MAP, 75 mmHg, portosystemic, pulmonary and cutaneous shunting. Spider angiomata contributes to a hyperdynamic, high CO state, often I by up to 50%. Alcohol excess is associated with cardiomyopathy. Cirrhosis is associated with a high incidence of cardiac dysfunction, cirrhotic cardiomyopathy. And concurrent, smoking is a risk factor for CAD. Preoperative assessment, including echo, where indicated, propranolol to reduce portal pressures. Hypoxia is common and multifactorial in CLD. Ascites causes splinting of the diaphragm, basal atelectasis and collapse. Excess PEEP will increase hepatic venous pressure and ICP. Tense ascites may affect respiratory mechanics. Consider percutaneous drainage. Consider echo if suspicion of pulmonary hypertension, very common in liver disease. The liver synthesizes all clotting factors, except factor 8. Coagulopathy is attributed to several mechanisms: desynthesis of clotting factors, regional techniques, cardiovascular, respiratory, pulmonary hypertension, coagulopathy. Dr. Fahad Butt, Dr. Ahmed Shabazz. And clearance of activated clotting factors, quantitative and qualitative platelet abnormalities and hyperfibrinolysis. Consider vitamin K. Reversal of coagulopathy with FFP, cryoprecipitate in platelets directed by thrombolistography, TEG, or similar point-of-care testing, P0CT. Ensure adequate provision is made for cross-X matched blood and clotting products. CO monitoring goal-directed fluid therapy, GDFT, may be useful. TENS ascites may impair renal blood flow, avoid hypotension and nephrotoxic drugs, and aim for urine output. 1 ml use of esophageal Doppler toe esophageal temperature probes is contraindicated. Treatment with 6 blockers may contribute to perioperative hypotension. A low CVP may reduce the risk of varices. Consider draining preoperatively as hypotension, hypoventilation, and aspiration are all increased with TENS ascites. Patients with liver disease have impaired hepatic glycogen storage and are prone to hypoglycemia. Check blood glucose levels regularly. Give 10% glucose infusions if 2 ml and monitor plasma K. Infections of the respiratory and urinary tracts are common. In the presence of ascites, spontaneous bacterial peritonitis may cause significant sepsis. Have a low index of suspicion. Intraoperative antibiotic prophylaxis should be given where indicated. Sodium chloride 0.9% is recommended first line, and sodium bicarbonate may be considered if significant acidosis. Addition of glucose-containing fluids if hypoglycemic. Caution is required as over-resuscitation with crystalloid may worsen. Cerebral edema, IM&SE injections risk hematoma formation if coagulopathy or thrombocytopenic, renal, portal hypertension, ascites, hypoglycemia, immune function. Fluid resuscitation, other considerations, Dr. Fahad Butt, Dr. Ahmed Shabazz, care with positioning, the skin may be fragile, muscle wasting may leave patients prone to neuropraxia and pressure damage. Hypothermia is common during prolonged surgery. Active warming measures. Warm blankets and warm fluids should be used. Choice of anesthetic agents to be used intraoperatively. Temperature regulation. Table 8.5 Anesthetic drugs in liver failure. Drugs safe in liver failure. Premedication. Lorazepam, induction, propofol, thiopental, etomidate, desflurane, sevoflurane, isoflurane, N0, atracurium, cisatracurium. Drugs to be used with caution may need reduced dosage. Midazolam, diazepam. Enflurane, drugs, contraindicated in liver failure, maintenance, halothane, possibly, TN muscle relaxants, opioids, analgesics, rocuronium, vecuronium, succinylcholine. Nrezi-NDEE, N-remifentanil, fentanyl, alfentanil, morphine, pethidine, NSAIDs, lidocaine, bupivacaine, paracetamol. Dr. Fahad Butt, Dr. Ahmed Shabazz. Postoperative concerns. Patients with advanced liver disease will need postoperative intensive care or high dependency care. Postoperative critical care management considered for all child PUA, B, C patients. Benefits of critical care include ensuring optimal management, renal, pulmonary function monitoring and correction of coagulopathy and metabolic disturbances. Postoperative analgesia, if already placed epidural. Continue for postoperative analgesia. 0.0625% solution of bupivacaine. Small doses of acetaminophen 325 mg 3-4 doses day. Fentanyl PCA well tolerated. Postoperative common complications, new onset of ascites, volume overload, worsening of hepatic encephalopathy, upper GI hemorrhage, sepsis, renal failure. Decreased liver function with coagulopathy, jaundice. Dr. Fahad Butt, Dr. Ahmed Shabazz. Liver resection, indications, metastatic colorectal adenocarcinoma. Benign and malignant X31-degree hepatobiliary tumors. Donor hepatectomy for liver transplantation. Liver trauma. Principles of anesthesia management. Major liver resection usually involves removal of 30 to 75% of functional hepatic tissue. Short-acting drugs should be used. Minimally invasive techniques should be used such as laparoscopic liver resection. Decreases intraoperative bleeding, transfusion requirements and postoperative ascites. It presents different anesthetic challenges due to pneumoperitoneum, with consequent hemodynamic instability. Drugs that might compound postoperative hepatic encephalopathy or which rely on hepatic metabolism should be avoided, e.g., benzodiazepines. Most resections are accomplished with minimal blood loss, but catastrophic hemorrhage may occur. Resection comments as with perihepatic dissection and identification of vascular anatomy. Intraoperative diagnostic ultrasound is often used to pinpoint lesions requiring resection. Bleeding occurs from either vascular inflow, portal vein, hepatic artery or venous back bleeding. Branches of the hepatic artery and portal vein to the segment of the liver to be resected have usually been ligated, so inflow bleeding should not be a major problem. The line of resection often passes through a watershed area between vital and devitalized tissue. Maintaining a low CVP reduces venous back bleeding. Remaining inflow bleeding may require intermittent portal vein cross-clamping. The Pringle maneuver results in a degree of ischemia, reperfusion injury to the remaining liver tissue, and potentially poor postoperative liver function. Minimized by intermittent clamping. Brief period of vascular occlusion followed by reperfusion before sustained ischemia. Preconditioning may be beneficial. Resection of tumors located in critical sites of the liver and very radical liver resections are now possible. The liver is totally excised and dissected ex vivo ex situ following perfusion with an ice-cold preservation solution. Healthy parts of the liver are then attached to the vena cava and reimplanted. This is a prolonged and difficult procedure and anesthetically similar to a liver transplant. Venovenous bypass is sometimes required. Preoperative, most patients are otherwise relatively fit, unless they have parenchymal liver disease. Those who have undergone neoadjuvant chemoradiotherapy are at higher risk as it can deplete functional cardiorespiratory reserves. The degree of planned resection plays a major role in modifying the anesthetic. Dr. Fahad Butt, Dr. Ahmed Shabazz. Technique as well as monitoring due to risk of bleeding and postoperative liver failure. Preoperative assessment should thus be tailored. Apart from routine investigations for any major surgery, particular attention should be paid to liver function including coagulation, Child-Pugh scoring and cardiorespiratory function, large bore venous access, arterial line. CVP monitoring may be used, depending on bleeding risk and predicted need for vasoactive therapy. Active warming. Regular monitoring of blood glucose is essential as there is a risk of hypoglycemia. Thoracic epidural analgesia is utilized to good effect postoperatively. Alternatives are intrathecal opioids, PCA, and wound catheters or a combination. Aim to preserve hepatic blood flow, thus minimizing liver injury. Intubation and IPPV with a volatile agent are the commonest way of achieving this. Isoflurane and sevoflurane may enhance ischemic preconditioning and help preserve hepatic function where the Pringle maneuver is used. Maintaining a low CVP reduces bleeding. This approach has reduced transfusions requirements. A higher CVP target may be necessary to reduce the risk of renal ischemia in patients at risk or in those with poor cardiac reserve. Techniques to lower the venous pressure include pre-resection fluid restriction, epidural boluses, head-up tilt and nitrate or diuretic infusions. Surgical manipulation of the liver can cause significant reductions in venous return with hypotension. Close communication between the anesthetist and the surgeon is essential. Early tranexamic acid decreases transfusion requirements. Blood components are required in massive hemorrhage or prolonged hepatic inflow obstruction or where very little hepatic tissue remains. Perioperative, fluid and hemodynamic management. Dr. Fahad Butt, Dr. Ahmed Shabazz. Point of care. Coagulation testing allows rational treatment. Intraoperative, coagulopathy is relatively uncommon. Peak disturbances and clotting are seen on postoperative day 2-3. Patients who have undergone 50% resection should initially be managed in an HDU for monitoring of liver function and to manage pain with either epidural or PCA. Postoperative liver insufficiency, coagulopathy or encephalopathy may develop in those who have undergone very major resections. This has practical implications for the timing of removal of epidural catheters, etc., which may require FFP cover. Postoperative renal dysfunction, hypoglycemia, sepsis and intra-abdominal infections occur more commonly in extensive resections or high-risk patients. Postoperative